طيب يعطيكم العافية. إن شاء الله اليوم راح نبدأ محاضرة الجزء الثاني من الديوريتكس. حكينا بالمحاضرة الماضية عن الديوريتكس، تعريف الديوريتكس وحكينا بشكل عام عن الديوريتكس كيف بيشتغلوا، وذكرنا أول جروب من الديوريتكس اللي هم كانوا فعليا الكربونيك انهيدريز انهبيتورز. اليوم راح نحكي عن الجزء الثاني من الديوريتكس اللي هم اللوب ديوريتكس والثايازايد دايوريتكس، وراح نبلش في اللوب دايوريتكس. بالبداية اللوب دايوريتكس are compounds in general هم عبارة عن extremely diverse chemical structure, and they are classified into three main classes or chemicals, classes of chemicals. أول واحد اللي هو الأورجانوميركوريال diuretics. الجروب الثاني اللي هي 5 sulfamoyl 2 or 3 aminobenzoic acid derivatives، ومن ضمنهم ينطبق عليهم الفيروسمايد as well as the butyranide. And then we have the phenoxyacetic acid derivative as ethacrylic acid, which is the third class. Okay, let's see how loop diuretics work first, and then we can see the various drugs of classes of drugs that belongs to loop diuretics. Let's look at the first group, let's look at the way they work exactly, and this is how loop diuretics work. They work specifically على a thick ascending limb, and thick ascending limb is very essential part for filtration of sodium. It's the most effective area where diuretics work, so these loop diuretics are the most effective diuretics لأنهم بيشتغلوا على most effective area. هلا if we remember from the previous lecture, we said if we want to look at the anatomy of nephrons, you will see that you have the thick descending limb as well as the thick ascending part. وحكينا عنها proximal convoluted tubules. If we look at this, we have the proximal convoluted tubules, we have the thick descending part, and then we have the thick ascending part loop friendly. وحكينا انه بالproximal convoluted tubules about 60 to 65% of the sodium get filtrated. So this is the majority of where the sodium filtrated. And we have about 25% of the sodium get filtrated in the thick ascending limb. طيب ليش لما نمنع الصوديوم reabsorption in the thick ascending limb is the most efficient؟ مش المفروض لو بنطلع وين الاريا اللي فيها أكثر sodium filtrated هي اللي بتكون more efficient in terms of diuretics؟ In theory this would be the proximal convoluted tubules. This is not correct لأنه حكينا المحاضرة الماضية إنه بالproximal convoluted tubules, if the drug work there, even if they prevent reabsorption of sodium in this area, because the thick ascending limb has still a significant amount of sodium or percentage of sodium get reabsorbed, so that can be compensated no matter how much you prevent reabsorption in the previous part, which is the proximal convoluted tubules. That can be recompensated in the thick ascending limb in that area. بينما على العكس, if you prevent the sodium reabsorption in the thick ascending limb, which represent about 25% of the sodium get reabsorbed, that there is not much afterwards where the sodium can be reabsorbed. Only about 5% can be reabsorbed in the areas or the later parts compared to the thick ascending limb. So if you prevent the 25% absorption in this area and the thick ascending limb or majority of it, then you will generate a very effective diuresis effect. Okay, and so this is why loop diuretics are considered very effective as well, because they work in this area. 25% can be prevented, reduce the amount of sodium reabsorbed significantly. That results in a large diuretic effect that cannot be recompensated in the later parts of the nephron. واضح؟ طيب إذا loop diuretics are very effective diuretics, and they're called as well high ceiling diuretics. ليش؟ Why they're called high ceiling diuretics? Because the dose response curve for these compounds is linear over a wide range. What does that mean؟ يعني كل ما أنا أعطيت higher dose كل ما كان الديوريتك effect أفضل. يعني high ceiling يعني فعليا سقفه عالي، صعب توصل للماكسيمم level of diuretics. when you increase the diuretic amount you're giving to the patient, you will see a larger diuresis effect. And so this is what means high ceiling. على عكس مثلا لو بدنا نقارنهم بالثايزايد diuretics راح نحكي عنهم later on. You can only increase up to a certain level and then you will not see an increase in the diuretic effect. So The loop diuretics have a good dose response curve and is considered linear over a wide range. And their efficacy persists even in renal failure. So this is very important. A lot of these loop diuretics can be given to patients that have even renal failure. Okay, so again, why do we call them high ceiling diuretics? Because unlike thiazide or other diuretics which hit ceiling of efficacy relatively quickly because they act on distal tubules, the loop diuretics act on the thick ascending limb, and we cannot usually hit their ceiling easily unless we give extremely large doses. And so in other words, the thick ascending limb over here is really considered as an engine for the kidney that counter current the multiplier system later on. All right, so we know it's absorbed about 25%. Type, how do they exactly work, loop diuretics? They basically block what we call the sodium potassium chloride transporters, co-transporters. So when they block the sodium potassium, again, look at this. These are the thick ascending limb cells. This is where the urine is on that left side, and this is where the blood or interstitial blood area, fluid area, in this on the right side. These transporters, what they do, they pull the sodium in addition to potassium and to chloride to inside the cell, which were supposed now the sodium to go even uh, outside the cell back to the blood through another sodium potassium ATPase transporter. And so the loop diuretics work on those transporters and they block sodium potassium chloride co-transporters. So basically you block reabsorption of sodium from the urine back to the blood. As a result of that also, you will see that there is a loss of water طبعا لأنه wherever sodium goes, the water goes. You will see an increased calcium loss, as we can see over here. That calcium usually goes along with the sodium and potassium, and so you will see more of it get lost with the potassium or the sodium loss. And you will see sometime in some patient hypokalemic metabolic alkalosis, which means loss of potassium as well. Okay, so these are important results of blocking this sodium potassium chloride co-transporter. And these are basically you lose sodium, you lose potassium, you lose calcium. You lose calcium and magnesium as well, typically, when you use those loop diuretics. Okay? All right. So I think that's clear for how they work exactly and their mechanism of action. Of course, let's talk about the first group right now, which is the organomercurials. And these are an older generation of uh, those loop diuretics. These are the oldest loop diuretics were discovered in the 1920s, and they were used from the 1920s to the 1950s. From their name, organomercurials, فيهم mercury can. Structurally, you can see this is one of these compounds. It's called mercaptomerine, and you'll see this is the mercury that we talked about in their structure. And the mercury is important for their activity because the mercury basically, the release of mercury binds to the sulfur الموجود بالبروتينز on the tubular cells, and that inactivate the sodium transporters اللي هم شفناهم سابقا, which are sodium potassium chloride co-transporters. So they inactivate those by binding to their thiol site in their amino acid. Basically, that mercury binds to that thiol, and that inactivate the sodium transporters in the proximal tubules and the thick ascending limb of Henle that we talked about. Okay, so this is how they work. This is the mercury binds to the sulfur اللي موجود بالبروteins exactly. However, also they're not very good compounds because they cause a lot of serious side effects and toxicity. Mercury can accumulate in these tubular cells and other renal parts, and they can cause acute tubular injury, by the way. This is one of their side effects. It can cause interstitial nephritis, it can cause chronic structural damage with repeated use of those compounds. So this is very serious side effects that kind of made their use very limited in general. In addition, they have other limitation that they can't be given orally because of their poor absorption. لأنهم mercury is not absorbed well, and they're basically can be bind to any protein موجود بالGI before they even reach the systematic area. Also, after their parenteral administration, usually they take 1 to 2 hours, which is not an important limitation, but أكثر major limitation لما side effects poor absorption. And their activity depends on acid-base tests of the individual. They are ineffective when the urine is alkaline, and basically because mercury can be excreted easier when the urine is alkaline. And as we said, they cause nephrotoxicity اللي حكينا عنها because of the accumulation of mercury in the tubular cell. They could cause also cardiac toxicity because the mercury can interfere with the myocardial enzymes اللي have thiol, and they can bind to these thiol containing enzymes, and they can affect ion transportation in the cardiac system, which is very important because it could lead to arrhythmia or serious side effects related to cardiac side effects, as we mentioned or we talked about. Okay, so these compounds were not very useful, as we said, and they had many side effects. They can be given only by IV, not orally, and they have issues that also related to their cardio and nephrotoxicity. So the next group that was discovered of diuretics is the newer generation of the loop diuretics, and these were classified into two main groups: sulfonamide containing derivatives, and these are the most common, زي الفيروساميد, bumetanide, torsemide، وهدول كلهم sulfonyl containing compound, also sulfonamide containing compound. وفي عندنا non sulfonamide derivatives زي الفينوكسي acetic acid اللي هو الايثاكرينيك acid اللي هو more important for patient with sulfur allergy usually. تمام؟ طيب هلا السلفوناميد derivatives are the most common ones، واكثر واحد مشهور يمكن من هذول اللوب diuretics اللي هو الفيروساميد، and this belongs to anthranilic acid. عندنا derivatives of benzoic acid زي البيوميتانide as well as sulfonylurea compound like torsemide. And you, as I mentioned, you will notice all these compounds have the sulfonamide, and so if the patient has sulfur allergy, you should replace those compounds with the ethacronic acid اللي هو طبعا له its own really bad side effects that we can talk about, and really bad toxicity profile because of its electrophilic nature. طيب خلينا نحكي عن أول جروب اللي هم الsulfonamide containing compounds اللي هم الانثرانيليك acid, and we will talk in the next slide about these compound sulfonamide derivatives, and these are the most common. The two main groups that are used are the sulfamoyl 2 and 3 aminobenzoic acid derivatives. ولما نحكي ال 5 sulfamoyl, these are the structures of these two main groups that we will talk about. The first one اللي هي the 5 sulfamoyl 2 aminobenzoic acid, as we will see. So this is the benzoic acid. Let's draw the structures on the structures here, and this is what we call as a benzoic acid. Yes, this is the structure of benzoic acid. So we have the benzoic acid. This is the group benzoic acid. Okay, and then we have on the 2 position، لأنه بنرقم من هون من الكربون اللي جاي على البنزويك أسيد على الكربوكسيليك أسيد أول شيء. We have the 2 amino، صح؟ 2 amino benzoic acid، وننساش طبعا في عنا على الكربون نمبر 5 sulfonamide عفوا اللي بنحكي لها 5 sulfamoyl. تمام؟ 5 sulfamoyl 2 amino benzoic acid. This is the structure. On this side, you will have the same name, except it's on the 3 position you have the amino. Okay, so this is 5 sulfamoyl and 3 amino benzoic acid derivative. تمام. So it's 5 sulfamoyl 3 amino acid 3 amino benzoic acid derivatives. I can write this down if you want. طبعا هي كلمة واحدة بس عشان المساحة قليلة. benzoic acid. تمام. So this is the name of that compound. طيب هلا these two compounds let me erase whatever I drew over here. But these two compounds, these two classes of compounds are very commonly used as diuretics, and the difference between them is just really where the amine location is, صح? The difference is where the amine location is. طبعا هذا difference مهم لأنه راح نلاقي هون in general إنه هاي الأمين بحالة the first group, which is the 2 amino group, is basically this R can have only very limited number of substituents that are active. When the amine at number 2, there is only very limited number of substituent مكان ال R. ممكن انك تستبدلهم يضل الكومباوند active as loop diuretic. تمام؟ Okay, so this is very important. بينما هون you can have a wide range basically of substituent and these and when the amine at the 3 position. Okay, لو بدنا نحكي بس بشكل عام عن structure activity relationship things in general, basically you will see that. So it's really important to talk about the different things here that we will talk about. First of all, we have to have a carboxylic acid, and that carboxylic acid is important because it will be negatively charged at physiological pH, and it binds where the chloride in the transporter. مش حكينا في عنا transporters sodium potassium chloride that will be inhibited because this has a negative charge. It will simulate الكلورايد like negative charge وراح يرتبط هناك ويعمل interaction مع where the chloride should bind on these transporters. So this is number one. وجود الكربوكسيليك acid جدا مهم. For the activity وجود السلفونامide number two is also essential for the activity. وجود السلفونامide is also essential for the activity. Number three, we will see this X is electron withdrawing group. This will be an electron number X3. الإكس هاي لازم تكون electron withdrawing سواء كانت chlorine, bromine, nitro, fluorine, various kind of things that can be used as electron withdrawing. ونمبر 4 اللي هي وجود هاي الأمين عليها various substituents. إذا كانت على 3 position بقدر أستخدم many substituents: butyl, ethyl, propyl, cyclopropyl, cyclobutyl, whatever will be all active. So this is in this group اللي هي هاي الجروب اللي بتكون فيها الأمين. لو بدنا نحكي عشان بس نكتب رقم نكتب بلون آخر اللي هي بتكون 3 amino. Okay, on the 2 amino it's also the same requirements. وجود carboxylic acid 1, وجود sulfamoyl 2, وجود electron withdrawing 3، ووجود الأمين عليها السبستيتيوت 4. بس الاختلاف الوحيد بينهم إنه هون برجع بذكر الأمين هون has very limited number of options that we can use as a substituent to create an active compound. طيب خلينا نشوف examples عشان نحكي هذا الحكي ما يكون نظري فقط. On the next slide we'll talk about the first group اللي هي 5 sulfamoyl 2 aminobenzoic acid اللي هي الأمين راح تكون على 2 in this case in this group. وحكينا ال R is very limited number of functional groups, or sorry, substituent can be when the amine is in the 2 position. And these are furfuryl, benzyl, and thienylmethyl. These are the 3 substituents that can only produce active loop diuretics compounds. لاحظ انهم cyclic compounds, 3 cyclic compounds، واحد عليه أكسجين، واحد عليه سلفر، وواحد فقط basically benzene ring. تمام؟ هاي ال 3 substituents فقط that can produce an active diuretic. خلينا نشوف example على structures. أول structure اللي هو الفيروساميد. طيب structure of furosemide, which is one of the most active basically compounds and most commonly used compounds as loop diuretics. What do you classify it? We classify it as 5 sulfamoyl 2 aminobenzoic acid. ليش؟ لأنه عندنا هاي الأمين موجودة على number 2 carbon number 2. So it's 2 amino acid with 5 sulfamoyl موجودة عندنا carbon number 4. We have the 5 sulfamoyl. تمام؟ What is the substituent in 5 sulfamoyl؟ اللي هي أول substituent. Okay, اللي هي هاي السبستيتيوت صح؟ This one which we call as furfuryl صح؟ ولذلك اسمه furosemide. شو اسمه structure is furosemide لأنه وجود الفurfuryl بنسموه furosemide بسموه أو يطلق عليه furosemide. So furosemide is very active and very commonly used basically loop diuretics. And they act by inhibiting the sodium potassium chloride co-transporters because of their negative charge over here on the carboxylic acid. Of course, the pK of this carboxylic acid is around 4, at pH would be fully ionized that carboxylic acid. So basically you'll see this has a full negative charge, and that competes with the chloride location, or basically the chloride binding site. So it competes with this chloride binding site on these co-transporters and blocks the chloride transportation with sodium and potassium. So this is how they work. The next also example of these 5-sulfamoyl 2-amino benzoic acid derivative اللي هم these compounds. This is the next one اللي هو الازوسيمايد. الازوسيمايد, as you can see, it has a unique structure. First of all, in compared to furosemide, شو الاختلاف بينه وبين الفيوروسمايد؟ أول إشي عندنا وجود هنا بدل فيورفيوريل عندنا ثاينيل ميثيل. الاختلاف يعني فقط وجود السلفر. تمام؟ لكن الاختلاف الأهم واللي بدي أركز عليه أكثر واللي ضروري تكونوا عارفينه بالستراكشر اللي هو وجود تترازول رينج. تمام؟ This is called tetrazole. تمام. هلا عندنا هون أكيد زي ما حكيت قبل شوي ثاينيل ميثيل، مش كثير مهم ومش كثير افكت، يعني بيختلف كبير عن اختلاف الفيوروسمايد، لكن الاختلاف الأكبر بالأزوسيمايد. Basically if you look at the structure it has a tetrazole. طيب حكينا قبل شوي عشان يكون الستراكشر active لازم يكون عندنا elements هون. As we can see in the structure we have to have a carboxylic acid. In this structure you don't see a carboxylic acid. So what's going on here? Tetrazole is a bioisosteric replacement for carboxylic acid because tetrazole at physiological pH will be ionized, negatively charged, with a negative charge. And so that you will see that this, let me erase this, what I drew here, to be able to draw the next thing I want to talk about. But you will see that this amine is negatively charged at physiological pH. And the pK of that amine is 4.9 at physiological pH. So it's acidic, so it will be fully ionized to negatively charged compound at physiological pH to be like carboxylic acid. تمام? So this amine will have a negative charge over here, and so that resembles a carboxylic acid. This is we call as bioisosteric replacement. المفروض هذا الكونسبت إنكم أخذتوا عنه سابقا بالميديسينال كيمستري 1. So tetrazoles، راح أرسم التترازول هون very briefly. Will have a negative charge similar to carboxylate at physiological pH. تمام? So they are the same more or less at physiological pH, tetrazole carboxylate. Okay? So this is your carboxylic acid in the compound azosamide. Azosamide is very unique because it has tetrazole in its structure. This tetrazole allows for the structure to also have a better half-life in general as well. طيب نقطة أخيرة بدي أحكي على الفيروسامide as well as azosamide. And these two compounds they bind well to the albumin, and so basically to be able to work these compounds has to be filtrated into the urine عشان يشتغلوا. حكينا في عنا هنا transmembranous cells وعنا co-transporters لازم يطلعوا للurine outside to block these basically these two co-transporters من الurine area تبعت cells. And so if they bind very well to the albumin, how they get released back to the urine? Basically through using some transporters that we call them as these transporters are called as OAT, or what we call organic anion transporters. So من اسمهم, these are transporters that transport anions mainly. So these compounds are negatively charged, they get transported to the urine out, so basically excreted out of the kidney into the nephron and the tubular area where the urine is. And so this is how they get excreted. Now the issue is that sometimes if people use NSAID, these NSAIDs can compete with these transporters as well. if تذكروا لما حكينا عن NSAIDs فيهم carboxylic acids, so they can compete with those transporters. So NSAIDs can reduce the efficacy of these loop diuretics because they compete with them on the same transporters needed to take them to urine area where they can work on the co-transporters and block these co-transporters. Okay. All right, so this is the summary for this slide, and furosemide as well as isosamide, as in these two structures, you have to know that these are 5-sulfamoyl 2-amino benzoic acid derivative, وفيهم unique moiety fluorophoril. In the structure of furosemide, it's negatively charged at physiological pH, same thing as azomide, and dotetrazole. Physiological pH will be negatively charged. وعندنا thionyl methyl as well in the structure. Okay, so these are the two compounds from this group that we only gonna talk about, 5-sulfamoyl 2-amino benzoic acid derivative. هلا راح نحكي عن الجروب next group اللي هي 5-sulfamoyl 3-amino benzoic acid derivatives. And this is the 5-sulfamoyl 3-amino acid is the next group in the same class that we talked about اللي هي وجود الامينو benzoic acid derivatives. You will see that this structure again has an amine at the 3 position. هذا الاختلاف, the main difference between this compound and the previous compound. And you will notice that these as well have the electron withdrawing group in their structure similar to the azosamide, furosemide. هناك كان عندنا chlorine, برضه you'll see هنا different kind of electron withdrawing. هلا the main difference زي ما حكينا انه هاي nitrogen accepts a wide range of substituent now when it's at the 3 position, صح? So these substituents can be methyl, ethyl, propyl, butyl, and it was found out that the N-butyl group على هاي النيتروجين اللي هي على 3 position is perfectly optimized for hydrophobic pocket of these sodium potassium chloride carriers. So this is very important that they found this butyl group اللي هي 4 carbon unit when it's attached to nitrogen increase the binding affinity by 40 to 60 folds. So it's a huge jump in affinity of compound compared to furosemide. So this compound pumetinide is 40 times at least more potent in its inhibition. So if you need, in theory, if you need 1 milligram to inhibit the compound of pumetinide to inhibit the sodium potassium chloride co-transporters, how many milligrams you need to inhibit basically the same transporter using furosemide? You need 40 times. So this 1 milligram basically of pumetinide is equivalent to around 40 milligram of furosemide. And so this is a jump in its activity, in the activity or the inhibitory activity of these compounds, just simply because of, mainly because of وجود هاي النيتروجين على position 3 ووجود البيوتيل عليها. واضح؟ فهذا أهم اختلاف عندنا بهذا الستركشر. And of course you'll see there is also this difference in this electron withdrawing group, بس مش كتير مهم. لو حطيت كلورين كمان راح يطلع compound very effective the same way. بس the difference وجود 3 nitrogen على 3 position. Okay, so that difference made the compound 40 times more potent. In fact, pumetinide بنعطى للpatient at dose 1 milligram, can be increased of course, but can be typically given 1 milligram, and it's equivalent to 40 milligrams to furosemide. So that slim change أو التغيير البسيط إنه والله النيتروجين تحولت من 2 position بالfurosemide to the 3 position in pumetinide, that made this big difference in addition لوجود البيوتيل group على هذا structure. Okay, so that is very essential and important kind of a change that made a big difference in pumetinide. Okay, so the pumetinide is really unique compound by its potency as well. هنا في another structure مش كثير مهم، ما بيهمني احكي عنه يعني كثير لانه استخدامه اقل من البيوميتينايد، لكن فقط للتذكير اذا البيوميتينايد in the next slide has carboxylic acid in its structure، وجود السلفامويل مهم، وجود electron withdrawing group as well is very essential، وهاي اليونيكنس وجود ال N-butyl عنده على ال 3 amino, as we can see that made the structure 40 times more potent compared للfurosemide صح؟ حكينا عنه. Is used for edema, hypertension as well as heart failure, hyperkalemia and hypercalcemia. And this structure is soluble in urine. It does cause ototoxicity. وليش يعني they cause ototoxicity, these compounds you will see similar to furosemide as well, they can cause ototoxicity. They're typically reversible ototoxicity, and because they can inhibit as well the sodium potassium chloride in the tissues of the ears, so this is why they cause ototoxicity. So this is a side effect from the compound reaching the sodium potassium chloride co-transporters اللي موجودة بالتشوز اللي بالإير, specifically a tissue called stria vascularis مش كتير مهم عندي, but that transporters when you inhibit these transporters in the ears, that cause ototoxicity by interfering with those transporters and their work as ion transporters. It is reversible, of course. Then once we stop the drug, you will see that the patient will get back their hearing after the removal of the drug, because this is a reversible inhibitor, and so that reversible inhibition is important, and that will basically result in an ototoxicity that's reversible. Okay, it could cause hyperuricemia and hypokalemia, and that's related basically to their activity. Specifically لما حكينا عن الهايبوكاليميا لأنه بيخلوا potassium also to be excreted. There is a question also for you, and I would like you to look up why they cause hyperuricemia or increase in uric acid. And that's important to know from their structure. It's related to their structure why they cause hyperuricemia. تمام؟ يا ريت تعرفوا هذا, بدي أتركه as a homework for you guys to look it up and find why these compounds cause hyperuricemia. Okay? The next group or the next compound I will talk about is torosomide. And torosomide basically is a compound that has unique structure. كل الstructures اللي حكينا عنهم سابقا فيهم sulfamoyl benzoic acid. Basically you'll see sulfonamide in the structure, and you see a benzoic acid, 5-sulfomoyl, you see nitrogen as well. In this compound you'll see, first of all, it's not a benzoic acid, صح? It's a pyridine structure, so this has a pyridine unit. And it also doesn't have a carboxylic acid. It does have sulfonylurea. هاي الجزء هنا بنسميه عبارة عن sulfonylurea. تمام, this is sulfonylurea. Sulfonylurea at physiological pH has a negative charge. So this nitrogen will be negatively charged. وهذا الحكي resembles carboxylic acid. So this, if you ask yourself where does the negative charge comes from, this is where it comes from, on this nitrogen. لأنه هاي النيتروجين ليش بتصير negatively charged next to two electron withdrawing, carbonyl وsulfonate. These are two strong electron withdrawing groups. So the presence of these two electron withdrawing groups basically makes this nitrogen very acidic, will get negative charge. لكن structure wise كمان ما فيها sulfonamides. Missing الsulfonamide unit اللي موجودة كانت على ring replacement. طبعا هذا it's a unique structure. It's different than the previous two structures, like furosemide, bumetanide. However, the structure has also a longer half-life, and this is the main advantage of this compound, that has a longer half-life, about 4 hours compared to 1.5 hours. Why it does have a longer half-life? Because generally it's more non-polar in this case, and because it's non-polar, على عكس الfurosemide, which is very polar because of the carboxylic acid, or it's excreted unchanged usually in the urine, لأنه ما بيحتاج يصير عليه phase 1 metabolism. هذا بيحتاج يصير عليه phase 1 metabolism to be excreted. So it needs to go through phase 1, and that's typically cytochrome B in this case. تمام؟ طيب شو معناته هذا الحكي؟ معناته لازم لسه يروح من خلال phase 1 يصير عليه cytochrome B oxidation and eventually get excreted. So that takes a little bit longer than الfurosemide, وبالتالي له longer half-life. In addition, its main advantage has about 80% oral bioavailability compared to furosemide, which only has around 50% bioavailability. So it's more consistent in terms of oral dosing, and it's more consistent in terms of how much dose you need to give for the patient to achieve the diuretic effect that you really need to reach. the main issue of this compound is that you have to be careful if you give it with warfarin, because warfarin is also substrate for the same cytochrome B subtype that this compound uses for metabolism, which is called cytochrome B2C9. And so there will be a competition if you give warfarin to the same patient, as well as torsemide. So you can give torsemide. It's used exactly like the furosemide as well as bumetanide. Same efficacy more or less. لكن يعني same efficacy as furosemide, not as bumetanide. Bumetanide is much more effective than both compounds. لكن هون الادvantage is longer half-life, better oral bioavailability. Basically because it needs to go through phase 1 before phase 2 to be excreted out. تمام? Okay, so you will see that all these structures, I'm just going to erase everything I drew over here on the structure to talk about the last point. You will see in the previous structures, furosemide, bumetanide, as well as this one, they have a sulfonamide unit. هاي مع انها مش السلفوناميد اللي بتكون مرتبطة على الرينج مباشرة زي السابقة، لأنه هاي بتختلف شوي عنها. فبتلاقي فيها هاي السلفوناميد بهذا structure، بالفيروساميد عندنا سلفوناميد، بالميثانايد عندنا سلفوناميد. حكينا this could cause allergies for some patient. So in that case, you have to be careful. If the patient has sulfa allergy, you have to give those compounds with extreme cautious. If this happen, if the patient has allergies to these medications because of sulfonamide, the only option for them that can be used in this case اللي هو this compound ethacranic acid, and this is called phenoxyacetic acid. And if you look at, this is the structure of ethacranic acid. So this is phenoxy in the structure, and this is acetic acid, صح? This is the acetic acid. So it has the same use as furosemide, bumetanide, the same exact use. It inhibits sodium potassium chloride co-transporters اللي موجودة بالثيك acidic limb. وجود كاربوكسيليك acid مهم، negatively charged، وهذا اللي بيخليه يرتبط where the chloride binding site is and block that sodium potassium chloride co-transporter. تمام. Okay, why is it used? Because it mainly can be used for patient that has hypersensitivity to sulfamoil containing drug زي الدرug اللي حكينا عنهم قبل شوي، الفيروساميد، bumetanide, as well as torsemide. Okay, هل هذا الدرug يعني هو side effects free? That's not true. It's not side effects free. It does have a serious side effects as well. And the reason for this side effect is because of this unit. And this unit over here, which is called as, if you know what the name, you should know. This is called as Michael acceptor. And that Michael acceptor is highly electrophilic moiety, صح? So what does that mean? That means if there is any nucleophile has partial negative or full negative charge جاي من البروتين، ممكن يعمل attack على هاي لأنها very reactive electrophile ويرتبط عليه. So this compound can easily alkylate any nucleophile in the proteins of the kidney or other places as well, like the inner ears اللي حكينا عنهم, and could cause ototoxicity. But in this case, because it binds irreversibly to the protein, راح يسبب لنا irreversible ototoxicity. And so this could cause some irreversible ototoxicity to many patients because of its basically covalent binding to the proteins in the inner ear. So we generally reserve this drug only for patients who have severe anaphylactic allergies to the sulfa drugs, and basically to these sulfamoil containing drugs اللي حكينا عنهم زي furosemide أو bumetanide سابقا. تمام؟ طيب أنا يعني هلا بدي أكتب السلايد، أحاول أكتب لكم بس بالميكانيزم to show why this moiety السلايد القادم why this moiety is highly electrophilic وكيف ترتبط covalently مع البروتين. فراح أرسم فقط this unit only in the next slide. Okay, so as I said in this slide, I'll just draw basically the ethacronic acid moiety that's important, which is the Michael acceptor moiety اللي حكينا عنها سابقا. وهي هي المويتي الأهم. طبعا بإمكاني أرسم باقي الستركشر، مش مشكلة، فقط عشان أوضح، عشان تكون الأمور واضحة للجميع. تمام، لكن اللي بيهمني فقط أنا راح أحكي عنه هذا الجزء اللي هو في المايكل أكسبتر، ولذلك راح أمسح ما تبقى من هذا الجزء من هون، مش كثير مهم عندي، راح أمسحه هون عشان أوضح الأمور. راح أستبدله فقط وجود هيك الويفي لاين to indicate there is a part there، أو أحطه as R. طيب هلا لما يكون عندنا بروتين، خصوصا البروتين اللي فيهم ثايولز، الامينو اسيد اللي فيهم ثايولز بالبروتين، شو اكزامبل عليهم؟ اللي زي السيستين. الثايولز are highly nucleophilic، وعندنا هاي الجزء اللي هو highly electrophilic in this part which is what we call Michael acceptor. اوكي طيب همسح هذا مشان اوضح شو بيعمل الثايول. الثايول بيجي بيعمل nucleophilic attack على هاي الكربون، and the electrons goes back to this area to the bond between the carbonyl and this carbon, and then the flow of electron continues to go back to the oxygen. So what happens is you get this protein now covalently bound. Okay, just to make it look better. Okay, so this thiol is covalently bound to this drug. Okay, just to make sure we draw the full mechanism, خلينا نرسمهم different colors to make things easier. So let's do the protein blue color, for example. خلينا نعمل drug as red color. تمام. So this is the drug. اوكي اتوقع واضحه يعني. طيب هلا شو بيصير؟ راح ترجع الالكترونات back to the carbon and then back to here, and that will generate this compound. راح ارسم الجزء هذا التسهيل. راح يكون هاي الكربون عليها نيجاتيف تشارج، وعندنا كربوني وهاي نيجاتيف بوجود اني بروتون بالجسم راح ترتبط عليه. تمام. فراح نرسمها مرة ثانية وأخيرة فقط. طيب إذا هون شو صار؟ صار the protein is covalently bound to the medication, which is in this case the compound we just talked about اللي هو ethacrinic acid. And that will cause damage to the tissue, of course. So that damage means what? Means auto, if it happens in the ear specifically, راح يعملنا autotoxicity, as well as other kind of toxicities, the GI side effects and so on. So this medication, because if it's reactive, Michael, كل هاي المشكلة صارت because if it's reactive what? Because if it's reactive Michael acceptor over here, that moiety causes a serious side effects. And so this is why reserved only for patients with high allergies to sulfurs or serious allergies like anaphylactic shock. All right. So إن شاء الله يكون واضح الميكانيزم اللي كتبته المايكل اكسبتور. يعني very simple. You should know that if you took organic chemistry and other sources. طيب إذا حكينا عن اللوب diuretics بشكل عام، وحكينا عن عشان to summarize loop diuretics for now to make things easier، حكينا عن furosemide. Let me just use the red color. So حكينا عن furosemide here as the first example. furosemide فيهم sulfonamide furan من اسمهم، and furfuryl اللي حكينا عنها هاي المويتي and has a good potency has bad absorption or variable absorption. That's why حكينا torsemide is a better option for higher bioavailability. However, it is a cytochrome B metabolite, so you have to be careful with warfarin. Structurally حكينا فيه pyridine وسلفونيليوريا، وحكينا على البيوميتينايت اللي هو أهم شيء وجود ال N-butylamine makes this structure 40 times more potent because of its hydrophobic properties, binding better to hydrophobic pocket in the sodium potassium chloride co-transporters. واخر شيء حكينا عن الايثاكرينيك اسيد اللي هو الالفا بيتا unsaturated ketone. وعندنا these are sulfur safe compounds, however they cause autotoxicity because of their Michael acceptor as we mentioned before. These are the medications. حكينا عن furosemide, azoxamide, pimetonide. هذا مش مهم عندي. حكينا عن torsemide، حكينا عن الايثاكرينيك acid، بس برضو هذا المستراكشر عندي مش مهم. Okay, so in general if you need high potency you look for the N-butyl chain of pimetonide. If you need consistent oral absorption and once daily dosing, you look for torsemide. If a patient has self-allergy, you switch to ethacrynic acid. But however, you have to accept there is a risk or side effects related to the Michael acceptor group. So basically, understanding the medicinal chemistry allows you to predict interactions. زي ما حكينا المايكل acceptor, which is well known to cause side effects, and that chooses the right molecule for the right patient, and this is really important. Okay, طيب هلا رح نحكي هيك بنكون خلصنا اللوب دايوريتكس، وراح نحكي فقط. إذا بالجزء المتبقي من المحاضرة رح نحكي عن الثيازايد diuretics. With thiazide and thiazide-like diuretics, these are compounds work on the distal convoluted tubule part, which is this side of the nephron. And you can see that this is the distal convoluted tubules, as we know, it only excrete about 5 to 10% of the sodium. So it's very little amount of sodium or percentage of sodium being excreted. So these diuretics, they're not as potent in terms of their diuretic effect like loop diuretics, but they still have some good uses. These diuretics work on prevention or blocking the sodium chloride co-transporters. These are co-transporters that transport sodium and chloride together intracellularly to the distal convoluted tubule cells, and then from inside the intracellular area, the sodium will be excreted back to the blood, or basically reabsorbed back to the blood with the help of these sodium potassium ATPase. Now what happens to the chloride that got reabsorbed also inside the cells? There is as well as an ion channel that takes this chloride with the sodium back to the blood. So the net effect will be reabsorption of sodium from the urine back to the blood and the chloride as well. And there will be an excretion of potassium. In this process as well, what happens is that because of the reabsorption of sodium, there is a co-ion transportation, which is for the calcium. So the calcium gets reabsorbed by sodium calcium ion exchange basically channels, and that calcium gets reabsorbed back intracellularly with this ion channel, and then the calcium will be taken back to the blood with these calcium sodium exchange basically enzymes that takes one calcium atom inside the blood and then one sodium inside back to the intracellular area. So the net effect of these processes is that sodium goes inside to the blood and calcium will go inside as well at the same time. And so basically these thiazide diuretics, what they do is that they block these sodium chloride co-transporters. So the net effect will be release of excretion of sodium into the urine, more sodium, and so more diuretic effects on the urine or the tubular area. تمام. هلا with the excretion of sodium, what happens is that the body try to get more of the sodium from the blood back to the intracellular area, صح? And that in exchange of that, you'll see more calcium get reabsorbed to the blood. Sodium leaves out to the urine, and more calcium goes inside to the blood. So there will be a net effect of sodium excreted, more calcium get reabsorbed. So there is an increase of calcium reabsorption. So these medications work well for diuretic effect, of course, but they also have other effects, which is the calcium, enhance the calcium reabsorption. This can be useful especially for patients that have stones in their kidneys, because stones are typically made of calcium. So if you can take calcium back to the blood from the urine, there'll be less calcium precipitating in the urine, less chances of stone formation. There is a smaller application that was less popular, which is osteoporosis, because you can reabsorb calcium into the blood, increased calcium level in the blood, but that's not so effective, honestly, for osteoporosis. So this is not a good application. Okay, so again, the thiazide diuretics work on the distal convoluted tubules. They enhance sodium excretion. They increase calcium reabsorption to the blood, and they work on this part, which is the distal convoluted tubule only. And they're called thiazide and thiazide-like diuretics. Let's look at their structure briefly, and this is the first we'll look at the general structure of these thiazide and thiazide-like diuretics. So let's look at the thiazide. Thiazide structure, as you can see, is what is thiazide? Thiazide are made of benzothiadiazine 1,1 dioxide, and this is the structure of benzothiadiazine. Let me draw a ring around the ring over here. So this is the benzothiadiazine unit. So I can redraw the structure here just to make it very clear for everyone. So we have a nitrogen, carbon, we have another nitrogen, and then we have a sulfur, and then we have a double bond here. So this structure is called, of course there's a hydrogen here, this structure is called benzothiadiazine. So this is the core structure for all of these various thiazide diuretics. تمام؟ طيب كيف بنرقم هذا الستركشر؟ بنبلش دائما من السلفر، من الهيتيرو اتوم هاي 1 2 3 4. طبعا ring junction is not numbered 5 6 7 and 8. Okay, so these structures are called sometimes benzothiadiazine 1 1 dioxide. ليش 1 1 dioxide؟ لأنه عندنا هون على السلفر راح أمسح رقم 1 بس راح أحطه هون. عندنا 2 oxygens on this structure, so it's dioxide 1 1 benzo 1 1 dioxide benzothiadiazine. Okay, so this is the core structure. طيب هلا what do we have? What is really important in this structure? In this structure, you will see that there are certain elements that are very, very essential. And the elements are, first of all, this sulfamide at position number 7 is very important. It's really important to have this sulfamide. تمام? That sulfamide is essential for the binding, and the sulfamide group in the 7th position is a prerequisite for diuretic activity. So you must have the prerequisite sulfamide act in that position to be able to have a binding of these compounds to the basically sodium chloride co-transporters. تمام? So these sulfonamides are believed at physiological pH to have a negative charge. So there will be one hydrogen loss to create a negative charge, and that binds also the chloride binding site in these sodium chloride transporters or co-transporters. So this is very essential to have the sulfonamide. It's important to have electron withdrawing group as well. يعني that electron withdrawing. راح تلاحظ انه هنا في شبه بينهم بين هذول الستركشرات اللي شفناهم سابقا. They have sulfonamides, you have electron withdrawing group, and this is also very essential for the activity. So this is the substitution at position number 6, must be electron withdrawing group, and it's called as activating group لأنهم electron withdrawing group essential for diuretic. They can be chloride, bromide, trifluorocarbon, or nitro group as well. And this will increase the acidity of your sulfonamide. So it will enhance the chance of your sulfonamide being negatively charged at physiological pH and binding to the chloride binding site in the sodium chloride co-transporters. So that R has to be electron withdrawing. What is also in the structure is important was found out that this double bond between carbon number 3 and 4 are basically, if you reduce it, you will result in an increase in activity, and this is why we call it hydrochlorothiazide لأنه بصير عليه reduction للchlorothiazide, which is one of the thiazide diuretics. تمام؟ الhydrochlorothiazide is one of the thiazide diuretics, and this double bond is reduced in this compound hydrochlorothiazide, and this results in an increase in potency of around 10 times compared to the previous compound. تمام. Okay, the last thing اللي هو position number 3, important to have substituent. You can have various types of substituent, and that determines the potency usually and the duration of action. Okay, let's talk about pharmacokinetic of these compounds. Most of these thiazide diuretics are well absorbed after oral administration, and their onset of action usually within 1 to 2 hours, with a Tmax of 3 to 6 hours. They're extensively bound to plasma protein, and they go very little by transformation and is excreted to the kidney usually as is, basically typically as is, or sometimes they can be glucuronidated or sulfonated. They're known to cause hypersensitivity because of the sulfamoyl moiety زيهم زي الستراكشرز اللي حكينا عنهم سابقا. Okay, they can cause hypokalemia زيهم زي كمان loop diuretics. They can cause hypercalcemia or hyperuricemia, again similar to loop diuretics. وحكينا طلبنا منكم why they could cause hyperuricemia بالloop diuretics. نفس السبب راح يكون ينطبق على thiazide diuretics. تمام. Okay, so these compounds, as I said, they increase also increase the calcium level in the blood, and that increased reabsorption of calcium in the proximal tubules. They also, I think the answer exists here in this slide, that the thiazide may compete with the secretion of uric acid, leading to hyperuricemia. وهذا هو جواب الهومورك اللي طلبناه منكم، موجود هو عندنا بسلايد هون. Anyways, so they increase the level of uric acid in the blood, they increase the level of calcium in the blood, as we mentioned previously. Let's take a look at the structure of chlorothiazide. So this is the chlorothiazide, and basically if you look at the structure of chlorothiazide, it has all the structure activity relationship elements that we talked about. صح؟ عنده الستراكشر أهم نقطة اللي نحكي اللي هي الكور structure اللي بالجزء عندنا. And this is the core structure اللي حكينا عنه البنزو thiadiazine structure. موجود عندنا السلفونامide which is negatively charged at physical pH زي ما حكينا، وهي the cause of allergies sometime as well in some patients. صح؟ حكينا وجود هنا electron withdrawing مهم to increase the acidity of the sulfonamide. صح؟ هذول 3 elements اللي حكينا عنهم. وإذا بنطلع على structure, as we can see, it has the core structure for thiazide diuretics. It is an inhibitor for the sodium chloride co-transporters اللي حكينا عنهم، بس بعد ما يصير negative charge هون negatively charged sulfonamide, and that results in increased excretion of sodium chloride. What is it used for? Used for hypertension as well as heart failure. تمام. طيب هلا حكينا كمان في عندهم certain side effects اللي هي زي الهايبركالسيميا، وحكينا زي الهايبرuricemia, which is something that could increase the chances of gout attacks. why حكينا السبب ليش بالسلايد السابق، طلبنا منكم homework بس already موجود answer for this. And that basically an important thing to talk about, the hyperuricemia is caused by thiazide because they compete with the uric acid excretion, and so that results in an increase of serum uric acid levels, and that could cause gout, as I said. Sometimes they have also other side effects that are less common, but we probably should know about, like hyperglycemia and hyperlipidemia. They could impair basically insulin, release of insulin, as well as other side effects, زي hyperlipidemia, although they're much less common compared to the hypercalcemia as well as hyperuricemia and the hypokalemia that we talked about. Okay, and the next medication راح نحكي عنه اللي هو hydrochlorothiazide, and the hydrochlorothiazide structure you'll see in the next slide, which is this is the structure. The only difference between chlorothiazide and hydrochlorothiazide من اسمه hydro اللي هو reduced double bond. So the double bond over here between position 3 and 4 is reduced. وحكينا that results in an increase in potency for this compound compared to chlorothiazide, about 10 times more potent than chlorothiazide. So it has also very good potency compared to chlorothiazide. In addition, that reduction, so first of all, we said increased potency, صح؟ اللي هلا حكينا عنها. And the second thing that it also was found out that this could basically cause less inhibition of carbonic anhydrase. الكربونيك انهيدريز inhibitors حكينا عنهم بالمحاضرة السابقة، وحكينا فيهم كلهم سلفوناميد ميت اذا بتتذكر، وهي مهمة جدا السلفوناميد للاكتيفيتي تبعت هاي الكومباوندز. هدول الكومباوندز has similar structure بوجود السلفوناميد. So they can cause this as a side effect to inhibit الكربونيك انهيدريز. مش اشي مفضل اني اعمل inhibition للكربونيك انهيدريز لانه that could cause acidosis, metabolic acidosis. So in this, because of the reduction of this double bond over here اللي حكينا عنها, that results in less carbonic anhydrase inhibition. So there is less ability to inhibit carbonic anhydrase than chlorothiazide, which is a good thing. You don't want the carbonic anhydrase to be inhibited. Otherwise, we have the same side effects that, like before, hypercalcemia, hyperuricemia can happen, as well as hypokalemia from these compounds. So this is hydrochlorothiazide is the most commonly used compared to chlorothiazide, as I mentioned before. Okay, I think we by this we finished the thiazide diuretics. المحاضرة الجاية إن شاء الله بنحكي عن thiazide like diuretics، وبنكون هنا باقي thiazide diuretics والجزء المتبقي من الديوريتكس، ويعطيكم العافية.